So thank you very much, Axel and David, and for the invitation. And it's a pleasure to be here this afternoon. And for the next 15 or 20 minutes, going to review what's happening in the advanced disease setting with regard to drug development in pancreas cancer. And as Axel mentioned, there really is a lot happening. I think there's been a reinvigoration in the area of drug development in this disease, and probably that's in part attributable to now the fact that we have some new combinations to build upon. So moving on here, how do I move on? Actually, oh, sorry, this one. So this is the agenda. Going to just briefly review standard therapy, Frontline, to look at novel therapeutics, what's happening in the frontline setting, what's happening in the second line setting, and interspersed review some of the ongoing studies in pancreas cancer. So by way of introduction, these facts are well known to everybody in the room. This is a very complex disease. It has a formidable biology based on the fact that it has a complex microenvironment. Essentially, immune cells to a greater extent are excluded. It's characterized by genetic complexity with four key genes that are mutated in this disease, but none of which are targetable in terms of therapeutics. There's primary drug resistance, and we don't have right now any validated biomarkers for decision-making in this disease, although there are some hints regarding several to come for the proximate future. This is the spectrum of available drugs, and you'll see gemcitabine started the era in the late 1990s. We have erlotinib, which is FDA approved in combination with gemcitabine in 2005. FOLFIRINOX is not actually approved by the regulatory authority, but obviously widely used frontline. And gemcitabine and nab-paclitaxel in 2013, and possibly MM398 in a second and subsequent line setting, potentially to be approved later this year. Worldwide, there's one other drug, and that's S1, which is available in Asia, but not in North America or Europe for pancreas cancer. So a reminder again of the key combinations used frontline. This is the Protege Cohort 11 study comparing FOLFIRINOX to gemcitabine in ECOG performance status 0 to 1 patients who have metastatic disease. This was stratified based on performance status, primary tumor location, and center, and endpoint being overall survival. These are the curves, a clear difference in favor of FOLFIRINOX, 11.1 months versus 6.8 months, with a hazard ratio of 0.57, and now widely utilized essentially in many settings in pancreas cancer that we'll review. And here's what's happening in terms of FOLFIRINOX-based studies in the adjuvant setting. A modified version of FOLFIRINOX has been looked at compared to gemcitabine for resected pancreas cancer. In the borderline setting, the Alliance have completed a pilot study, and it's positioned to be developed further, looking at FOLFIRINOX followed by capecitabine and radiation, and then surgery, and at the back end, 2 months of adjuvant gemcitabine. We'll look at the WashU group's experience with a novel agent in a second, but you'll see here there's a relatively short list of novel agents being combined with FOLFIRINOX, and there's probably a few reasons for that we'll touch on. SBRT is being evaluated following FOLFIRINOX in locally advanced disease. And in the metastatic setting, we'll have the first cooperative group experience with FOLFIRINOX, hopefully to be reported in the next couple of years. And it's looking at the hyaluronidase enzyme inhibitor, PEG-PH20. And then not an area that we're going to touch on today, but we can gladly touch on this in the questions, is there's a lot happening in the immunotherapy field in pancreas cancer. And an example here is looking at a maintenance strategy of checkpoint blockade, looking at ipilimumab and GVAX, the allogeneic vaccine that's been developed from Hopkins following FOLFIRINOX treatment. So we have one reported experience of a novel agent combined with FOLFIRINOX, and these data were presented at the GI ASCO meeting earlier this year. drug PF04136309, doesn't have a name yet, but it's a CCR2 antagonist. It basically inhibits one of the chemokines. It reduces monocytes and reduces infiltration of tumor-associated macrophages. So this trial looked at FOLFIRINOX on its own, FOLFIRINOX combined with CCR2 in a setting of borderline resectable and locally advanced pancreas cancer. And it was really built around the correlatives, and essentially it was identified that combining the CCR2 antagonist with FOLFIRINOX led to an upregulation of a variety of cytokines along with an encouraging response rate with very acceptable safety profile for this novel agent. And undoubtedly we're going to see this developed further in pancreas cancer. There's a lot of preclinical data that I haven't shown you here that underscores these data. So this is in locally advanced and borderline resectable disease, but I think there are many applications in the advanced disease setting as well. So moving to the other major regimen that's now in widespread use, these are the data from the MPACT study conducted in performance status 70 to 100 patients with also untreated metastatic pancreas cancer, Frontline, comparing gemcitabine and nab-paclitaxel to gemcitabine on its own. And these are the outcome. This was the initial reported survival that was in the paper in 2013, looking at a difference in favor of gemcitabine and nab-paclitaxel, 8.5 months versus 6.7 months, and a hazard ratio of 0.72. And that has led to the routine utilization of gemcitabine and nab-paclitaxel as first-line treatment. So a big question is, how do we use this and which is the preferred choice for a given individual? And we don't have a lot of data to guide, except for some age, certainly performance status, patient preference, choices of trade-offs of requiring infusional therapy and a Mediport versus alopecia, et cetera, can factor into the discussion. But I think it is fair to say that gemcitabine and nab-paclitaxel is probably more applicable to a broader population of patients, those that have a less robust performance status, those that perhaps are a little older. And very importantly, I think in regard to drug development, there are two things. One, that there's an opportunity to build on this. And second, and this is in contrast to FOLFIRINOX, there's a clear pathway forward in terms of regulatory authority approval. And that, as you'll see, is now leading to this new era of adding novel agents to gemcitabine and nab-paclitaxel. Remember, we've seen this already 10 years ago or 15 years ago when we added a novel agent to gemcitabine. And this, I think, has resulted in a lot of interest again in drug development in pancreas cancer. And we'll go through some of these. So where do we go from here in terms of novel approaches? And there are a lot of opportunities. The issues of stromal depletion, looking at targeting stem cells, metabolism approaches, which are beginning to be integrated as part of experimental therapies. We'll look at genetic subgroups in pancreas cancer, and not so much going to touch on, but these are also areas of very, I would say, active drug development, key signaling pathways, immunotherapy, and radioimmunotherapy strategies. And there's even now a late-stage phase 3 trial, which is looking at radioimmunotherapy in a third-line setting, which is kind of striking, right? We don't have an approved second-line therapy yet, but we have a third-line phase 3 trial that's underway in this disease. So this is an incomplete list, but just gives you some of the spectrum of agents, looking at the RAS pathway, looking at hedgehog, looking at stroma, looking at SARC, JAK, and this will be a substance of one of the debates a little bit later on. We'll spend a little bit of time just looking at BRCA and where this fits in terms of targeted opportunities. We've mentioned vaccines in terms of checkpoint inhibitors, modified bacterial antigens, listeria, Algin Pantucell, which has completed an Adjuvant trial, CD40, which there's data from UPenn, and now some of the beginnings of approaches with CAR T-cell strategies targeting mesothelin and CEA in pancreas cancer. And also an alkylating agent, which has completed phase 3 testing and for which data are pending. So this just looks at this graphically for those that like to depict more visually in their mind therapeutic opportunities, and I won't belabor it again, but I think it's a nice graphic illustrating a lot of what's going on in terms of pancreas cancer with regard to targets. So moving now to some specific examples of what's happening in the field, and again using this, going back to the title of the talk, building on standard combinations. We have some data with PEG-PH20, which is the hyaluronidase enzyme inhibitor. And just a reminder that the stromal microenvironment in pancreas cancer is very rich in hyaluronin. This enzyme has been combined with gemcitabine in a phase 1b study, which showed that it was safe. Mainly myalgias were the main dose-limiting toxicity. It's given as a subcutaneous injection, and supported by some very interesting preclinical work showing degradation of the stroma, altered interstitial pressure, and enhanced drug delivery, which putatively means potential improved benefit from cytotoxics. And there are two randomized phase 2 studies underway, one using nab-paclitaxel and gemcitabine as the backbone, and we'll have data shortly to be presented on this. And the other, the trial that we mentioned that's underway in the SWOG setting, in the intergroup setting, and this is in the phase 1b context at the moment, just looking at the safety of PEG-PH20 with FOLFIRINOX, and then we'll go on to a randomized phase 2 trial. Public information on this, both of these studies were stopped for a period of time because there was an excess of thromboembolic events in the PEG-PH20 arm. Both studies have now modified their entry criteria and are using different strategies with regard to prophylaxis. Low molecular weight heparin has been used in the gemcitabine and nab-paclitaxel trial, and aspirin being used in the FOLFIRINOX study. So I think that's also going to be interesting and see in terms of how primary prophylaxis works in pancreas cancer. So what about other strategies? Well, Notch and cancer stem cells is a very topical area in cancer in general, and certainly in pancreas cancer. So just a reminder, cancer stem cells are these intrinsic resistant population of cells that are associated with resistance and responsible for tumor regrowth and metastasis. We know that Notch is sort of integral here and is involved in self-renewal and proliferation of these cells. And Notch 2 and 3 in particular have been implicated in many cancers, and certainly pancreas cancer, and is putatively a poor prognostic biomarker. So one of the goals is by interfering with cancer stem cells, maybe there's a therapeutic advantage. And there's a fair bit of data now. The data I'm going to show you is looking at OMP5905, or trextumab, which is a monoclonal antibody against Notch 2-3, and this has been looked at preclinically in pancreas cancer, and you'll see that there's fairly profound tumor growth cessation by combining the Notch antibody along with cytotoxic therapy. This trial originally started prior to the approval of gemcitabine and nab-paclitaxel, so used gemcitabine as a backbone, but you can see the signal looks even more robust with gemcitabine and nab-paclitaxel, where there was growth cessation. And this was in the context of minimally passaged human xenografts, so a model system that's as close perhaps to the human system as you can imagine, respecting that these are not perfect at the end of the day. So a phase 1b study has been completed, and we reported the updated data at ASCO this year. This is looking at the antibody combined with gemcitabine and nab-paclitaxel. It's given every other week, fairly well tolerated in terms of diarrhea, infusion reactions, and possibly some additional thrombocytopenia. There was one DLT of diarrhea, and I think an interesting signal, respecting the fact that it's a selected patient population in the 40 patients, some of which had gemcitabine as a backbone, the majority of which had gemcitabine and nab-paclitaxel. Median PFS was 5.6, median OS was 11.5 months, and a 38% response rate. I didn't show this, but in the randomized phase 2 is powered to look at a subset of Notch 3 high expressors, so a very poor prognostic group. And in that group, the signal was very robust, of about 18 months. So the hypothesis is that this antibody may work best in Notch 2-3. And the follow-on to this is the ongoing randomized phase 2 study, which is underway, which has been recently redesigned. It originally had a PFS endpoint for a greater robustness in terms of the signal and to help with a decision point as to whether it should be taken further. The primary endpoint of the randomized phase 2 has been changed to OS, and the N has been increased to account for that. So the primary endpoints are looking at overall survival and then specifically in the Notch 3 high expressing group. So this is recruited very rapidly and should finish later this year and potentially have data hopefully for next spring to present. So looking at a different topic of metabolism in pancreas cancer, arginine is an important enzyme. It's a semi-synthetic amino acid. We all take it in daily, but there's data showing that arginine depletion may be of therapeutic benefit. And this has been now looked at extensively in mesothelioma, in HCC, where there's almost a completed phase 3 study looking at this concept as a single agent. In pancreas cancer, we know that arginate succinate lyase, the enzyme that's involved in metabolism, is deficient in a majority of patients. And there's a lot of preclinical data suggesting that combination with cytotoxic therapy may augment this metabolic inhibitor. And an ongoing study will look at this in combination again with gemcitabine and nab-paclitaxel with an initial phase 1 dose escalation period looking at 2 dose levels of ADI-PEG20, which is the arginine depleting agent, and then an expansion cohort in untreated pancreas cancer. So moving to the issue of genetic subgroups in pancreas cancer, and this is perhaps a setting where we do have the hint of a biomarker that we can begin to use for decision making. So if you take an unselected population, about 5 to 8% may have a germline mutation of BRCA1 and BRCA2. In populations of people with Ashkenazi heritage and pancreas cancer, the chance of finding a mutation is significantly higher, as it is in familial pancreas cancer and as it is in familial breast and ovary cancer families. The most common mutations that we look for, and certainly in the Ashkenazi group, are the founder mutations, 2 in BRCA1 and 1 in BRCA2. And there is a therapeutic opportunity here in that this is the Vogelstein wheel looking at the various pathways that have been therapeutically exploited in pancreas cancer. So DNA damage repair is one of the critical areas, and this is where platinum drugs and experimentally PARP inhibitors might have a role. Underscored by the concept of synthetic lethality, which suggests in BRCA-deficient cells as opposed to normal cells, there's ineffective DNA repair and a heightened chance of therapeutic benefit from DNA-damaging agents, be it platinum, be it irinotecan, be it other agents. So we've conducted an initial experience looking at veliparib, which is an oral PARP inhibitor combined with cisplatin and gemcitabine. We had 2 groups of patients. This was not randomized. Half had a germline BRCA mutation, and half did not. In the initial goal was to determine the dose of veliparib with cisplatin and gemcitabine. That was defined. This is an example of a patient with a germline mutation who had a striking and durable response that's now been maintained for 2 years. Of course, it doesn't tell us whether it's the platinum, it's the veliparib, or it's the combination of both. From this study, we defined what the dose would be of veliparib with cisplatin and gemcitabine. Looking at the outcomes in BRCA patients versus non-BRCA patients, there was a striking difference in terms of tumor response, disease control, and we saw very little activity in non-germline mutated patients. And that leads us to this ongoing randomized phase 2 study, which is being conducted from New York, but including contributions from Israel and from Toronto and Chicago for germline mutated BRCA and PALB2 patients. So that's looking at combining a PARP inhibitor with chemotherapy, but I know it's not exactly the topic, but I just want to mention that there is some single-agent data for PARP inhibitor on its own in pancreas cancer, a pre-treated population, and you'll see 22% of 5 people had an objective response. So again, suggesting that it's a real value in a subset of patients. And there indeed now is a phase 3 trial in pancreas cancer. This is for, again, germline mutated patients who've had prior platinum therapy, who get randomized to a maintenance question of aliperib versus placebo, double-blinded. And this trial is globally recruiting patients at the moment. And for those that may be interested, there is a series of other trials, some single agent, mostly, and the randomized phase 2, which we've mentioned in pancreas cancer. So what else is happening in this disease? And I'll just close with some of the studies in the frontline setting. There's very few phase 3 trials at this juncture. One was reported at GI ASCO earlier this year. The non-ATP inhibitor, the mitotic inhibitor, was a negative study. We're waiting the data on the alkylating agent TH302, which will hopefully be available fairly soon, although in an unselected patient population, I think this is probably a fairly ambitious target, but for the group of patients that really do have hypoxia in their tumor microenvironment, this may be a particularly attractive strategy to capitalize upon. And then to wrap up here in terms of frontline studies in pancreas cancer, and this is an incomplete list, but just wanted to highlight some of the agents that we didn't talk about that are in development. There's now the first completed study using gemcitabine and nab-paclitaxel as a backbone, looking at the HRC protein inhibitor, and we'll have data later this year on that. JAK1 and 2 inhibitors are going into the frontline setting. Democizumab, which is an anti-DLL4 and also stem cell toxin, is going to just starting in a randomized phase 2, and a variety of other agents that are somewhat earlier in development, IDO inhibitor, gamma secretase inhibitor, and WEE1 inhibitor, which is being combined with gemcitabine and nab-paclitaxel with some toxicity early on and requiring a revision of the treatment strategy. So in view of time, I'm just going to summarize here that there's an expanding array of treatment options for good performance status patients. There's a host of targets and pathways being evaluated. And as we discussed, I think there's a logic and a way to why gemcitabine and nab-paclitaxel is that backbone, because it's perhaps an easier platform to build upon, and because there's a path to drug approval if a trial is successful. FOLFIRINOX, because of the complexity of the regimen and the toxicity and the fact that it's not FDA approved, I think is a more challenging pathway forwards in many regards. And not focused on, but glad to send anybody the slides who might be interested. There's a lot also happening in the second and third line setting, sort of capitalizing on some of the signals that have been observed in some of the trials that we mentioned, and we'll come back to the JAK discussion in one of the debates. So thank you.